Yes, we are live now.
Please start, Rajesh.
Hello, hello. I'm audible, sir.
Yes. Yes, you are audible.
Hello, hello, hello.
Yes, we can hear you. Please go ahead.
There is a myself, Dr. Suraj. I am presenting this Thursday clinic. There is a 4.5-year-old boy, first born non-consanguine marriage, resident of Kalwa, hailing from UP, brought by parents with complaint of fever 5 days back and weakness of left lower limb and upper limb since last 4 days. Child was apparently all right 5 days back, then developed low-grade fever which is relief on meds, not associated with the rash, joint pain, or headache. Then notice weakness left lower limb and upper limb that 4 days back when a child awakes from the bed while walking, falls repeatedly after 4 to 5 steps. And there is also difficulty while walking. That child was dragging his left lower limb uh, while attempted to walk, and there was slipping of slippers from the affected side while trying to walk. But child was able to get up from the bed and but not able to roll over on the either side. At the same time, mother also noticed that child was not moving his left upper limb, not that he's not able to lift his left limb above the level of shoulder. Also not able to hold the things in the left hand. Uh, Weakness of upper limb and lower limb non progressive. There is an improvement in the power of upper limb and lower limb. The child is walking without support in last 3 days, and weakness of left upper limb persists. So, sir, there is a correction. There is a improvement in the power of left lower limb only, and weakness of left upper limb is persist. And there was a deviation of angle of mouth to the right side while crying, and along with the accumulation of food on the affected side. Child was moving his right upper limb and lower limb in a normal way, and there is a no weakness noted in the right side. There is no cranial nerve involvement other than seventh cranial nerve. No history of bowel bladder disturbance. No history of headache, projectile vomiting, or blurring of vision. No history of weight loss or decreased appetite. No history of trauma. No family history of any blood disorder. No history of cyanotic spell or cyanosis. No history of loose stool. No history of recent exanthems, hematuria, oliguria, or any history of chronic drug intake. No significant past history, NC history uneventful, birth history uneven full term vaginal delivery, birth weight of 2.5 kg, no NICU stay, and child received birth vaccine. And there is no history of neonatal jaundice. Child is immunized till 9 months, which is partially immunized. Developmental before the illness, appropriate for the age, with a bowel belt control achieved. Dietary history eats from family pot mixed at 6 out of 7 food group consume. Calorie deficit of 115 kilocalorie and no protein deficit. And there is no similar illness in family, and family belongs to lower class by modified Kupus-Comi scale.
Okay, so now since he knows the case, you can start speaking that what will be your thought process with this chief complaint?
vascular injury or any space occupying
First, we'll
lesion.
talk of the anatomy. So, put it like this. So, where do you think is the anatomy?
Cerebral area, like
So,
cortical. Uh,
so why do you say it is central? Why not peripheral? First,
um,
let's talk of that.
Unilateral involvement is there, and
So, unilateral can be peripheral or it can't be peripheral.
can be peripheral.
Okay. So, why do you think it?
There is the involvement of proximal and more distal muscle, and as per history, there's the involvement of facial nerve also.
Facial nerve came up a little later, no? Okay.
At the same time, sir. Same time.
So, suppose we say for a minute that you take the facial nerve away. You'll add it, of course, it helps. But if you talk only of the weakness, are there any ways to decide whether this is central or peripheral?
Involve Involvement of muscle groups. Like, periphery is more involvement of the distal muscles.
What I'm trying to ask is that can we think of any situation or pathology where only one limb will be involved due to a peripheral cause? Peripheral cause means we are talking of a lesion either in the spinal cord or then in the nerve root or the nerves. So you have to think of a possibility. Can there be a possibility where spinal cord is involved such that only right lower limb or left lower limb is involved? Is it possible? Then you talk of ahead. Okay, what whether it's possible here. Can I get a weakness in one lower limb because of spinal cord involvement? Is the question.
compressive minor.
Peripheral nerve is involved a single, then we can have if compressive neuropathy or any spinal cord lesion, then we can involve one lower limb, sir. In this case,
So is there one uniform peripheral nerve which supplies the whole limb?
like any compression over there or like, then unilateral.
Are compressed like radiculopathy or anything.
I think when both the limbs are involved on one side, we need to first strongly think about the upper motor neuron lesion till proved otherwise. That's number one. Though if the story is starts with one limb, then moves on to another, that's a different story. So if the onset is almost together, then we take it as an hemiparesis. The question is, uh, do you have an upper motor neuron right at the pyramidal tract level, cortical level, or subcortical, or the internal capsule? Okay, all three will cause hemiparesis, especially with the facial on the same side. Down there, there are no apparently cranial uh, nerves involved, so we will not think about lower down, but cortical, subcortical, internal capsule. How would you differentiate between these three probable lesions?
If there is a cortical involvement there, there was a history of seizure, and aphasia can be there.
You see many times hemiparesis in old people. They may not have unconsciousness, they may not have seizure, nothing of the great kind. Okay. Why should they get seizure? If you have a middle cerebral gone, why should there be a seizure? There could be a weakness. So could the vascular lesion cause a seizure? You have infantile syndrome, no seizure, no unconsciousness. Same thing happens commonly in old people. So do you think vascular lesion causes unconsciousness, causes seizure? What is the difference between arterial and a venous infarct? Both are vascular. Any idea?
Infarct is also associated with signs of cerebral edema or raised intracranial pressure. But arterial is more of motor deficit and
What you have said is that arterial lesions are localized to the area that is supplied by that blood vessel, whereas a venous one has an encephalopathy because of a venous stasis and therefore is likely to have unconsciousness or many other symptoms. So I think because there is no seizure or because there is no unconsciousness, you can't get away from a arterial lesion, right?
So you come down to saying that this is
While just a caution, while somebody is complaining of a localized lesion, it's more applicable to monoplegia. If they say my right upper limb is weak, make sure that right lower limb or the left upper limb is normal. Because to the patient, he may have felt that this is because it changes the diagnosis immediately. From monoplegia, it becomes hemiplegia. Or if he has a right lower limb involvement and the left is subtly affected, he has a paraplegia. So your localization, your approach changes. So here, again, you will ask for it, but probably double hemiplegia, etc., are less likely.
The other thing is that even when you come lower down, even lowest, which is cervicomedullary junction, you will have no cranial nerve involvement. So that is not a common cause of a hemiparesis, but yes, it's also a cause of hemiparesis. So when you have no cranial nerve, you can be go up or extremely down upper motor neuron lesion, right? And therefore, facial often is missing in a hemiparesis. Not necessarily you should have a seven nerve, because when you have a tributaries involved, it could be patchy as well. Of course, if it's subcortical, then it's very much patchy. But that patchy is one limb involved more than the other. And to that extent, even anatomically, the facial is not as simple as we call up upper and lower motor. There are often mixtures in an individual, and just because of that, you cannot talk about upper or lower. It could be. It's easy for us as a clinician to talk about, yes, but many times those fibers are not exactly going the way the books describe, and therefore facial is very difficult. First, a mild facial is easy to miss, and often, if you see a patient a little later, it has already recovered, but still the weakness of two limbs are involved. So I think when you have an upper motor neuron lesion right at the top or theoretically right at the bottom. Yeah.
now you have all this negative history. So can you tell us one by one what you asked it for so that we can understand? Yeah.
Uh, there is history of no cranial involvement to localize the lesion, and history of bowel bladder disturbance, same for the localization of lesion. No history of headache, projectile vomiting, blurring of vision uh, for encephalopathy or associated with the red signs of ICT. For no history of weight loss, decreased appetite, for TBM, like for to rule out FOX, and no history of trauma, no family history of blood disease or PRC transfusion to rule out sickle cell or thal disease, no history of cyanosis or cyanotic spell to rule out embolic stroke causes due to TOF, no history of loose stool for uh, to rule out stroke due to dehydration, and no history of recent exanthem to rule out stroke followed by viral exanthem. No history of hematuria oliguria to rule out acute glomerular nephropathy, and no history of any chronic drug intake like L-asparagine.
Which of these conditions start with your history of weakness? Cyanotic spell start with weakness, or patient comes for cyanosis. Dehydration, diarrhea, he comes with diarrhea and dehydration, or suddenly comes with a weakness. So I think when you give a negative history, it has to be related to an individual case. Here is a story that starts from weakness. Which of these conditions start with weakness and then you say, I had also diarrhea? Correct. And therefore, don't give all possible causes in medicine. That's not an important thing of loose, negative history. Another, we have every time said that negative history should be such that parents feel it's not very serious to even report. Would somebody not report cyanosis? Would somebody not report head injury? They might have forgotten in the past. Okay. And therefore, don't give a long list. Today, I think in everywhere, we find a long list of negatives for a presentation with two or three symptoms only. Are we trying to say everything is possible? No. And therefore, to me, none of these things will come with the first symptom of a weakness. Okay. And therefore, none of these are true. We are not asking for all causes of hemiparesis. That's what you have written. So I think in clinical medicine, according to me, that's not the way to go, right?
Understood. Now, the moment you say this child was bang normal and the first event was the hemiparesis, so all those things will have a past history, no? So all that is gone, right? Come.
So my impression is 4.5-year-old boy case complain of fever and weakness of left side of upper limb and lower limb, non-progressive, involving proximal and distal muscle group with right upper motor neuron facial palsy and no other cranial involvement, with no stop seizure or altered sensorium in a uh, developmentally and birth as normal child, partially immunized with calorie deficit of 115 kilocalorie, is a case of left-sided hemiparesis secondary to thrombotic cause or a embolic cause. On examination, uh, child is conscious, alert, and oriented to time, place, and person. Posture-wise, left upper limb, there is a adduction at shoulder joint, extension at the elbow joint, semi-pronation of the wrist joint with open palms, and left leg was moving in the all the direction. Child was afebrile, heart rate of 103 per minute, which is regular. Respiratory of 23 per minute, regular thoracoabdominal type. BP, blood pressure of 96/62. The right arm in a supine position. Saturation was maintained on 97% on room air. Extremities warm. Carotid pulse bilaterally felt. Capillary refill time less than 3 seconds. There is no edema, pallor, cyanosis, clubbing. Anthropometry wise child is normal. On head to toe examination, head normal shape and size. There is no facial asymmetry. Eyes, ear, nose normal, spine, genitalia normals, and no neurocutaneous markers seen. On systemic examination, child is conscious, irritable on approach, oriented to time, place, and person, and right-handedness in speech is normal. On cranial nerve examination, cranial nerve first could not be tested. Second, On second cranial node, child was able to count the fingers and direct and indirect light reflexes present. And three, fourth, and sixth cranial node, eyeballs move in the all the direction. There is no nystagmus or squint notice. For fifth cranial node, not able to chew on the affected side. For seventh cranial node, child was there is an angle of mouth deviation to the right side on a crying, but able to close the both the eyes, and forehead wrinkling was present. Eighth cranial node was normal. For ninth and tenth, there is central position of uvula, gag reflex normal, and rolling of the foot from the affected side. For 11th cranial node, child is able to turn the head against the resistance and not cooperative for shrugging of shoulder. And there is a protrusion of tongue present.
Okay, wait 1 minute. Go back. So here when you yeah, when you said that is right-handedness, so left side is the weakness, no?
Yes.
In this child, left
Yes.
side is the weakness. So when you say right-handedness, do you mean that left is weak, so he is doing things with his right, or he is a right-handed person?
He is a right-handed person.
How do you know?
That
Just now left side is weak, no? So he will do everything with right hand. That doesn't mean he's a right-handed person.
this was a history given prior to the illness. That child was using its right hand predominantly for eating foods and all the daily
Correct.
activities.
Correct. So what I'm trying to say is that is right-handed is decided by history, not by what he is doing just now with his right hand. You understanding the difference I'm saying?
Yes.
Okay. Now, second nerve able to count fingers. I'm just asking that normally what all are you supposed to see under the second nerve?
Uh, visual field, visual activity, then fundus and reflexes,
And color vision.
color vision.
Very good. So able to count fingers corresponds to what visual activity?
Near vision.
So near vision means we can keep going far and also still ask. So at what distance are you supposed to check visual activity? Acuity? That screen is supposed to be kept at what distance? 60 centimeter. How do you express the visual acuity? What does that mean? 6 by 60 means what?
Normal person can see clearly at 60 centimeters, and but the patient is able to see at 6 meter, 60 meters and 6 meters. So his visual acuity is 6 by 60.
6 by 60 is right, what you said. So this able to count fingers corresponds to a visual acuity of only 6 by 60. Okay.
Yes.
So what I am trying to say is, this is a 5-year-old child, no? So in a 5-year-old child, you want to see with second now whether he is able to see well, he is able to focus, he is able to look around. Just counting fingers is not good enough. He needs to be better than that, is what I'm trying to say. Understood?
Yes, sir.
Slide.
On tone examination, there is a normal tone in the right upper limb, lower limb, and left lower limb, and tone was decreased in the left upper limb. Power wise, on the right side, power is 5 by 5, and on the left side, there is a power of at the shoulder muscle group and elbow and wrist, there is a 0 by 5, and power in the lower limb was 5 by 5. The child was now able to walk. Gait wise, there is a dragging of left lower limb with swinging around in an arc, and reflexes present on the right and on the right side. Superficial and deep reflexes present with plantar flexor on the both the side. On sensory examination, child was able moving his limbs on pain, that touch temperature and pain are normal on the both side, and not cooperating for the any joint and position sensation for cortical sensation. There is no cerebellar signs, no meningeal signs, and rest of the system are within normal limits, sir. On RS, there is a air entry bilateral equal, chest clear. There is a S1, S2, no murmur. For abdo soft, non-tender.
1 minute. So what signs did we get? Just enumerate the signs. You got low tone, left upper limb low tone, zero power, and plantar flexor, and so monoparesis of the element type, because low tone and zero power.
Sir, this is actually post course in word power.
No. We are training you how to argue in the exam. So now we are being bad examiners. So you have a one upper limb only involved, which is hypotonic. So this is a element paresis. No, there's no question of hemiparesis. So how will you argue?
Involvement of both upper limb and lower limb. Since that there is evolution in the course of word, their power has improved in lower limb compared to upper limb.
There are no upper motor neuron signs, no? So was it a lower motor neuron hemiplegia?
Above the level of C4 is involved. Lower motor involving both upper limb and lower limb. Should involve more part of the spinal cord to involve both upper limb and lower limb. In if it is being upper motor neuron, and a small part of small lesion in the brain, like internal capsule or in the subcortex, can explain the weakness.
I think if the history is right, then we have a hemiparesis. The story starts from lower limb. Okay. Now what we are examining is the lower limb is not totally normal. The gait is not normal. So your examination of power, tone, etc. could be all right, but there is some circumduction. So it has been a recovering lower limb, but the upper limb has not recovered at all. Quite a discrepancy. Okay. So the first question that we need to discuss is, how does hemiparesis start improving? Does it improve proximally, distally? Does upper limb improve first, then lower limb? What is your idea of its improvement? Because whenever we see an improving illness, we must also learn how does the illness get better. For example, a typhoid fever, fever is the last to disappear, but the patient starts feeling much better, appetite returns, sickness disappears, abdominal distension disappears, but fever still persists. Right? In pneumonia, the breathlessness disappears first, fever follows, but the cough even worsens. Correct? So what do you think about this recovery? Could you say how does the recovery of a hepatitis occur?
First affected part will recover first, usually. Since the child had a lower limb weakness first, so improvement is also being in the same direction.
And there will be, sir, improvement in the power, but weakness will be persist till disease completely recovered.
Such a discrepancy looks a little unusual to me. That's number one. The question is, are you really looking at pulse paralysis, which is something that improves fast? And maybe tomorrow the upper limb also will get better. Do you think it's a pulse paralysis?
If thoughts paralysis follow the convulsion for you did not have any obvious convulsion history. Focal convulsion.
Could it be a transient ischemic attack?
More than 24 hours, so not counting.
Could it be a vasculospasm? The word spasm means it could recover quickly, whether ureteric spasm, whatever. Do you think it's a vasculospasm? Because for a thrombosis or embolism, okay, to recover so much fast and discrepant looks little unusual. Okay. So could it be a vasculospasm? And does vasculospasm is one of the pathologies of a vascular disorder? We always say hemorrhage, embolism, thrombosis, vasculitis, and vasculospasm. So what does this vasculospasm mean? So metabolic errors can cause a vasculospasm. Okay. And you know typical malas, for example, come with hemiparesis, disappear, come again. And therefore, we start wondering what kind of pathology this is. Considering that it must be hemiparesis, considering that it has recovered so fast, it has recovered naturally. What can naturally come back? What is your thinking about thrombosis and all recovering? Right.
Sir is pointing out this is something which is very striking that it has recovered so fast. So it may not even be a complete block, as we say. So just a spasm which has recovered. And the difference is also too big. Here it is zero upper limb, and the lower limb has almost fully recovered. So that is also a very big difference. So we just keep this in mind. What it means, we don't know. We'll have to see further, right?
I think when any illness recovers much ahead of our expectation, keep in mind whether this could be some abnormality and might recur again or whatever. Okay. Obviously, this is not a complication. For example, 2, 3 days of severe diarrhea comes to you and you give something and suddenly the diarrhea stops. Are you happy? Parents are very happy. Why are you not happy? They came for diarrhea, so many loose ulcers. आपका हाथ लग गया ठीक हो गया. What must have happened?
Like anti-motility agents are being prescribed by someone. So it is not.
It's a complication. Could it be intussusception? Could it be hypokalemia and paralytic ileus? Could it be drug induced? Parents are happy, but you are unhappy. How do you know that these complications have occurred? He might have been lucky to get better, no? And therefore he looks sick. Okay. He's better, but looks sicker, right? That has not happened here, so we don't know that. We haven't seen such a quick recovery really, and therefore there is something amiss. We'll keep in mind, and you will have to tell us a week or two later what happened if you knew anything more, right?
We should also not forget 1 day of fever. This child has not gone in for a vascular event just like that. There was a 1 day fever, then there was no fever. So when there is fever, it was day one, and the paralysis came on next day. Am I right? So, I mean, it may not be directly infective in cause, but this particular fever, we will have to keep in mind whether there's an immunological basis. Fluid thrombosis, etc., there should be no fever. And if it is vasculitis, immunologically indicated, then the different areas of the vessel may have different degree of involvement. And therefore, improvement in one part of the body while not so much expected could be possible. So one has not seen so many cases of vasculitis improving in an unsymmetrical way.
Could it be iron deficiency anemia? Most common deficiency anemia causes hemiparesis, right? Why does it cause hemiparesis?
RBCs are not malleable, and there is thrombopoiesis, so both contribute for thrombosis.
MCHC of 23.2, platelet 2 lakh, and cling negative. Triglyceride levels are 158, cholesterol 90, HDL cholesterol 30, LDL cholesterol 28, and serum VLDL cholesterol 32. With RFT, LFTs, and PTN are in normal range. Serum electrolytes are normal. CT brain with angiography.
Rajesh, we can't hear.
No. CT angio reveals narrowing of the bilateral intracranial internal carotid artery, petrous and cavernous segments, with severe narrowing of the supraclinoid more than the clinoid segments, and multiple collateral vessels in the interpeduncular systems, suprasellar systems, along the M1 segment of the bilateral MCA, and along the posterior circulation in the region of bilateral crural ambient systems, giving puff of smoke appearance, mild narrowing and irregularity of the M1 segments of the bilateral MCA, right more than left, prominent of P1 segment of the right PCA and left PCOM, focal atherocalcific plaque in the A1 segment of the left ACA, which is suggestive of Moya disease.
Classically, Moya Moya would be a consideration when different episodes occur at different sites. That's typical Moya Moya. Now, looking backward, could it be that what presented as a hemiparesis were two different lesions, one milder, another more severe? But that's too much to kind of think about. Okay. And therefore, retrospectively looking at one that has improved so clearly, which started first and then happened second. So it could happen in a typical hemiparesis as well. So retrospectively speaking, two different ways of improvement might now suggest that it could be two different lesions. But that means there is a third lesion again, somewhere with a seven nerve involvement, maybe subcortical picking up one of those. But I think Moya Moya would not have been a consideration straight off. And typical Moya Moya is only different vascular lesions at often different sites. And that doesn't, but we have learned this, that disparities that we were not able to kind of explain now maybe, I'm not sure, I've never seen one like this, but maybe now that two lesions have come up at a different time, maybe over 24 hours theoretically, and one that came first is already recovering. The second one possibly will recover another day, and therefore this we could not have picked up by any good history, etc. So for you, the diagnosis of vasculitis thrombosis was acceptable, but we have learned something new now that when there is a disparity, which I could not have thought of Moya Moya just because of disparity, but we were making a point that why there was a discrepancy. Today we have learned something new, right? Good.
You want to try? Why not? Sure.
Okay, so we'll move on to the second case
So
for
go
today.
Yes, wait. What if you're finding it? I am.
Making one more point that the imaging may not really mean that you have a clinical counterpart seen in a patient. The lesions may have been anatomically there, but functionally they are not there. This is not unusual. Okay. What a clinician sees and what the image says cannot be very congruent every time. And therefore, the imaging has shown kind of multiple lesions. But for a clinician, there was only one kind of a thing. So that is not unusual. But again, this discrepancy might be, we will have to ask, you ask your neurologist whether such a discrepancy can make us consider two lesions coming at different times.
So now I think, as you perfectly said, going backwards, that must be the thing. The lower limb must have been just a spasm, and the upper limb is an actual lesion. They are showing so many lesions. And the second part, which you said we typically see in old age, you see a MRI of a senior person, it will show many lacunar infarcts, this, that, which is seen on the image. But in the person, you can't to pinpoint a neurological deficit. So they are the smaller ones, right? So here I think retrospectively what Sir said is perfect.
There is some segment of a vessel involved. It need not be pin one point. And if the segment is involved, then little bit of discrepancy in the upper and lower is can occur, and the recovery also may not be the same in that entire segment.
The image showed, if I know rightly, collateral salpicing. So now collateral means it has been there for quite some time. and which is asymptomatic, right?
The second, third time that whenever we had infantile hemiplegia, there has been an associated because of it is much more common than clearly. I mean, we will diagnose it only when you have recurrent or alternating or anything. Yeah. And if we should be able to pick it up early, maybe for almost every infantile hemiplegia where we have a thrombotic and no other cause, moya may always be there as one of the causes.
So Dr. Anjali has rightly said that imaging will overestimate the lesions and clinically it may be less.
Good evening, everyone. Myself, Dr. Amdekar. I'll be presenting the next case. My patient is a 2-year, 7-month-old male child, second by birth order, born out of non-consanguineous marriage, hailing from Shahpur, Maharashtra, Hindu by religion, brought by and informed by father, came with the complaint of weakness in both the lower limbs since 1 month and fever for 5 days, which was present since third day of the weakness, lasted for 5 days. The child was apparently all right.
That hourglass wala symbol is there, no? नहीं, उसके बाजू वाला. हाँ.
Child was apparently all right 4 weeks back when parents noticed that child was frequently preferring to sit after walking short distance and was not running, which gradually progressed to frequent falls while walking, followed by walking with support over the course of 4 days. And then there was difficulty in standing from sitting position over next 6 days. Child has been with us since last 3 weeks with no progression or improvement in weakness. Earlier, child could run and walk without support. Fever was undocumented, mild to moderate, not associated with chills, rigors, or rash. It was relieving on medication and then reoccur, having 3 to 4 spikes per day, and child was active in interfebrile period. Parents took the child to some local practitioner and was referred to higher center for further management. Past history: child is actually a known case of bladder extrophy, which was diagnosed at birth, for which child had one admission in past at 8 months of age requiring deepithelialization of the bladder. Child was advised for surgery at 1 year of age but deferred due to repeated viral infections. There is no history of vomiting, loose stool, cough, or cold. No history of altered sensorium, irritability, or convulsion. There is no history of change in bladder or bowel habit, although bladder and bowel sense cannot be assessed as child has bladder extrophy. There is no history of pain, no history of any recent immunization, no history of drooling of saliva or difficulty in swallowing, facial asymmetry or drooping of eyelids. There is no history of difficulty in raising hands overhead or rolling over or difficulty in breathing. There is no history of trauma, no history of Cox contact, or no history of similar episodes in the past. ANC history was uneventful. Birth history, full term section, LSCS in view of previous LSCS. 2.8 kg birth weight. Baby cried immediately after birth, and ICU stay was for 3 days as child had bladder extrophy with continuous dribbling of urine, and there was no neonatal jaundice. Child is partially immunized till 9 months. Development before the weakness is language delay was present. Other milestones were achieved. Dietary history: child was exclusively breastfed till 6 months. Then complementary feeding was started. At present, also parents are giving smashed food as child refuses to eat solid foods, and the diet is preferably a vegetarian diet. Family history is not significant. Uh, Summary: 2 year, 7 month.
Go back. Yeah. How old is the child? 2.
Years, 7 month.
So the first symptom is that the child was frequently preferring to sit after walking short distance. and was not running. What does that make you think?
There is some weakness.
No. Why weakness? Is the most typical history of a cardiovascular history. No, after walking a little, you want to stop. That means you are feeling breathless.
There was no history of breathlessness or difficulty in breathing, or no cardiovascular history or anything since birth. Any past history is also not there.
Past history means the cardiovascular problem has started now only. That's why this history has come now. Don't we say that in cardiovascular patients, they have limitation of activity? So this fits in that, no? So how will you separate it out? 2 years, 7 months will not be able to talk of palpitation.
Will complain of increased heart rate.
That is if the mother is holding the baby in the arms. So you rightly said that there is no dyspnea on exertion. So if this was cardiovascular or respiratory, then the baby would become breathless, then would stop, sit down, then the breathlessness would come down, and then the baby would start walking again. But that has not been reported, but you will have to ask. Okay, here you know it is neurological, but the starting could be exactly the same, but you have to ask. Now, if there is no breathlessness, then what else does it mean? So, typically, we learn or we understand that anybody who has weakness, they will not be able to walk. No, here he is walking a little and then sitting. So, what does that mean?
There can be myalgia or any local
Very good,
trauma.
very good. So, you start thinking whether there is pain that is happening on walking, whether the muscles are paining, or so when any part is not working properly or is weak, it gets tired faster. No, so that's how the muscles, if there is a subtle weakness, then they are getting tired faster. That is the second thing that comes to the mind. Okay. After that, progresses to frequent falls. So first, in general, why should a 2.5-year-old child have frequent falls in general, and then specific to this child?
While achieving milestone during learning to run, a child may have frequent falls,
What?
which can be normal.
So
But
how will you? Yeah. So first of all, why do they fall? If it is normal, then why do they fall? And the second is that how do you know it is normal? You are perfectly right, but I'm saying that if he is normal, then why is he falling? Chalo, huh?
Sense of proprioception or balance has not been established yet. Maybe.
Okay. Anything else? So there can be subtle, there is no perfection in the balance or perfection in coordination is one. And children are very enthu. So they want to do things very fatafat. So before they have, you know, established one position, they want to quickly get into a second position and a third position. So because of all that, they may fall. How do you know this is not a neurological disease? So you confirm that he is able to do so many physical activities, as in walking, running, jumping, climbing, which tells you power is normal, tone is normal, coordination is normal. So therefore, within limits, these little falls are normal, right? Now, in general, suppose a 2.5-year-old is brought to you for frequent falls. What will you think of? Beyond even nerve and muscle. Then we come down to this child. Okay, so one is balance issues.
Peripheral neuropathy. I think
Why means expand on that. Peripheral neuropathy is why is it making him fall?
not able to hold the slippers and cripple down and fall.
Okay, so not able to hold slipper is a sign of what?
Foot drop and peripheral neuropathy.
So you're mixing everything. So foot drop is a sign of peripheral neuropathy, and foot drop makes you unable to clear the ground, and that's why you fall. Correct? So that's one reason, correct. Slipping out of slippers or not able to hold slippers means what?
Weakness.
Your plantar grip is not good. Your foot has a plantar grip, and that is not good. So that means weakness of a different kind, and that again will make you lose your slippers, and it could also mean a sensory loss. Okay, and that is why you lose the slippers. So all these are different ways in which peripheral neuropathy can affect you. Anything else why you will fall?
Able to bear his weight, like weakness due to nutritional weakness.
Okay. So you to again add some adjective to that. Weakness, I am saying you will not walk only, no? So why fall? Weakness means you will not walk. Yeah, hypotonia, agreed, but something you have to add to that. Asymmetrical weakness. So you either have difference between the two lower limbs or difference between anti means extensor and flexor. That's why Duchenne's fellow falls. No, Duchenne's does not have a completely weak leg, but there's a difference in the power of his extensor and this. So that's why his foot goes down and he falls. Right. So asymmetrical weakness is important. Then tone. Tone is very important. So even before weakness, if you have a change in tone, again asymmetrical. So a spinal cord lesion can cause a change in tone, and one can have frequent falls because of that. Okay. Beyond the neurological system, can't see well, you'll fall, no? So vision related. Okay. Okay. There was rickets mentioned by somebody who was seeing the program on chat. So, do you think rickets causes frequent falls? And if yes, how? And if no, why not?
Frequent falls due to weakness and bowing of the leg.
Okay, weakness and bowing. So, does rickets cause weakness of the muscles?
No, bone.
That might cause them to fall.
Deformities of the legs may change the gait a little and it may cause them fall. Coming back to my previous question, rickets does not cause any weakness or it causes weakness. So there is something known as a hypocalcemic myopathy, which rickets can get. So it's not like a weakness as in 0/5 type of a weakness, but there is a subtle weakness. Can it be atonic seizure? So it can be theoretically, but atonic seizures are very, very uncommon. What is more common than atonic seizure? Where you will fall again? So what is drop attack? Is it a atonic seizure? It's a myoclonic seizure. Drop attack is a myoclonic seizure. It's a myoclonus, different from atonic seizure, right? Myoclonus. Yeah, right. Oh.
I think we should know the details of what do you mean by the first statement prefers to sit while walking, after walking. So I want to know whether while he tries to walk, does he stumble down and sit? Or does he voluntarily want to sit? Two things are different. If he has some neurological problem, then he suddenly stumbles down and sits. That is almost akin to falling. So the parents have not said falling. So it appears whether after walking 2, 3 steps, he prefers to sit. That's your cardiological problem. But here it could mean that he suddenly just stumbles down, which the parents feel he's trying to sit. And that could have taken us straight to a neurology. And we could have then said that likely we wait to see whether something more is happening. So many times one parent says something, it may mean quite some other thing to us. And some more details might be clearing such issues. And I was wondering what they sit after a walk. And after walk, how many steps? All those details could have made us wiser.
I think we ruled out the cardiac cause. It could happen as a result of pain, but there is no pain. So if the child is sitting after walking some distance, he is feeling weak, he is not able to continue walking, therefore he sits and he sits voluntarily. Not per se because of pain or none of the cardiological. Now, which is the weakness which will make him sit first? Is it the distal or the proximal? And the answer is proximal. Because if there's a distal weakness, there is fall. He does not fall in the history. It started with weakness. Now, if I have weakness of the distal muscle, I will fall. But if I have weakness of the proximal muscle, I know that I cannot, I will better sit. So this particular child has started with weakness of proximal muscles without pain. And it has progressed over a period of time to the extent that he knew that he just can't continue and he prefers to sit. So whether it was unilateral or bilateral, we don't know. But pardon me, bilateral. So bilateral proximal muscle weakness without pain or fever, starting and progressing in a relatively short time to such an extent that he was not even able to stand. So maybe it has progressed a little later also to involve the distal muscles as well.
So, sir, frequent falls are also there afterward,
Yeah.
which means distal
Yeah,
may also have come in. We
and
don't.
distal fall means at least he was able, if he doesn't stand and walk, he will not follow.
Yeah.
So he was at that time able to stand also. So proximal followed a little later in a short time by distal muscle weakness without pain, without fever, without cough.
And then it goes on to difficulty in standing from sitting position over next 6 days. So that is again a sign of proximal muscle weakness. Later. So now the question is now again like in the first case, is this central or peripheral? Why not central?
Sensorium and there is no altered sensoriums or convulsion or other signs, unilaterality, which cortical, it may be most commonly unilateral, it is bilaterally since the start, and symmetric also. So that's why maybe.
Agreed. So
Theoretically, a slowly developing hydrocephalus would present with problems in the lower limbs because if ventricles start enlarging, the first pressure is to the pyramidal tract, which are going to the lower limbs. Of course, such a thing really presents with the first change in tone, maybe a bit spasticity more than weakness. But bilateral lower limb involvement could be central. Another way, even a frontal lobe could do that. So we keep in mind that, but you're right, that there is no headache, vomiting, etc. And therefore we don't consider central lesion.
now, is it spinal cord or after the spinal cord, as in nerve roots, muscle, etc.?
Like to ask if sensory involvement is there.
Which is going to be difficult in a 2.5-year-old child. So you can't bank on that sensory involvement.
Child
Can be muscle disorder, the myopathy. Or,
It can be, but
mm,
we're just learning what all we should look at. We may not be able to perfectly differentiate. But if it is spinal cord, then what will you look at? So bowel bladder. So was he trained prior and he has lost control or something?
there is continuous dribbling of urine, so bladder wala to nahi. And there was no prior control established, so we cannot comment if there was.
Okay. Then anything else for spinal cord? So, so go back to what spinal cord diseases you have seen and what is the pattern of weakness. So what have you seen in the spinal cord coming as lower limb weakness?
transverse myelitis.
Okay. How does transverse myelitis come?
There is band-like sensation.
Band to theek hai, bigger patient, but what is the time frame of the weakness? Does it come like this? First sitting, then falling frequently, then get difficulty in getting up. Does it come like that? Spinal transverse myelitis.
Yes.
Yep.
Weakness
And
and acute.
And like at the level of it is upper motor neuron, and below it is lower motor neuron type of.
so one time weakness. I mean, most of the weakness will be seen right at the beginning, a big amount of weakness. It may progress a little, all that may happen, right? So it is not a progress over so many days, right? Then what else have you seen in
Compress
spinal cord?
Compressive
Compression,
myelopathy.
very good. So what is the standard way in which a compressive spinal cord myelopathy comes?
Usually a more slower progression is observed.
And
Pain is
pain
important.
and symmetry or asymmetry?
Asymmetry.
Asymmetry and tone. There is a tightness, there's a change in tone,
Tone.
spasticity. So, from the looks of it, just now seems less likely that it could be spinal cord. We will differentiate further on examination.
I think a slowly developing spinal cord lesion would be extradural, intradural, or intraspinal. Now, extradural typically would involve also some pain. Okay. Intraspinal would come with bladder bowel, etc. So I think we will, at this small age, pain may not be easy to pick up, but many of these children, while walking, they would get pains and they would refuse to walk. Weakness, of course, would be another thing, and that possibly indicates some pain as a reason. So extradural is more common, and one would. But we have here an extrophy of the bladder. There are two things that you keep in mind in this child. One is there is a congenital malformation. So what's the rule? Once you have a one malformation, look for another. So that's one clue. Second clue is in the family history you talked about. There has been an interval of 8 years between two children, and the mother and father are 35, 36. That's an age again where there are likely to be some more malformation, and you have already one. So are you looking for a malformation in the spinal cord? Okay, it could be intraspinal or extraspinal. And I think I would start looking at a congenital malformation as the first possibility, not acquired. The question is, would a congenital malformation present over 2 years when it has been present since birth? What do you think?
Says first, it will mostly.
So why would it keep quiet for a while? Extrophy was seen right at birth. Okay.
With growth of the vertebrae, growth and stretching.
Find the vertebral column, the spinal cord, everything has to be congruent. If not, then it's slowly present, right? Yeah.
You can have spinal canal stenosis with spinal claudication. That's another way. I mean, not in this case, but the third thing is when you have a bladder defect like this, you could have electrolyte disturbance with an affection of the kidney. And the genitals are affected. It's a midline defect. You don't know how many more are there.
For example, there could be some cysts there. Okay, this is congenital, and that could be at multiple levels as well.
Okay. And then of course, so in one way, if you look at this whole history, it is like a 5 year Duchenne's history compressed into 4 weeks, something like that, right? So it could well be a muscle also. So we'll see later between all these differences, right? Okay, but now we have fever also.
Uh, muscle weakness at this age in children is usually myositis. Not, neurodegenerative will not come so fast. And almost all myositis in children there is associated pain. Okay, so making a diagnosis of myositis in the absence of pain should be rare. So this is not myositis. This is not peripheral. So this is neurological in origin, spinal cord. And therefore, in the beginning, we were thinking whether neurological or non-neurological. This should be neurological, related to spinal cord. One malformation makes her a little more suspicious about the presence of the other. Either cord is one thing where the spinal cord as he grows, because there is a spike there, but either cord presents with manifestations first in the distal part rather than proximal part. Here, this is opposite of that. But I think spinal malformation should be the one which should be our first diagnosis. Where it is present and how, that will explain how the difference has occurred, but relatively fast in 5-6 days.
That was why I was a little uncomfortable that in 4 weeks from zero to so much progression for a malformation. That's why. But and now your myositis, your pain point is right, sir, but there is fever. Now, fever was undocumented, mild to moderate, uh, but there was definite fever, or we are not sure whether there was fever because it's undocumented.
Like the parents said that they were giving medication because they feel that the child had fever and the entire body was warm. So
They were giving medicines
they were
3-4
giving
times a
medicines
day.
3 to 4 times a day, after which it was relieved. And the child was actually active in interfebrile period, so it was mild kind of present.
And how long did this fever last?
5 days.
Only 5 days.
Yes, sir. On the third day of weakness, the fever appeared and lasted for 5 days.
Third day of weakness, 4 weeks back.
Huh.
Aditi mentioned tethered cord and a neural tube defect, like a syringomyelia.
I think in a short period, the congenital malformation which has got progression could be only because of two things. One, there is a fluid in the cyst, or there is a hemorrhage occurring. So, to my mind, then the cyst comes first, and therefore, possibly it's a cyst which is enlarging in a short period and causing one.
Okay. Okay, Mahesh is asking why not GPS only? So, any thoughts on that? Can it be GPS?
4 weeks, sir. Till that time, it should have attended also.
Yeah, so
It progressed for 10 days and it was static. It was not ascending. There should have been some progression.
yeah, so could it agreed? So GPS can also get static at some point. So could it be GPS which has got arrested at that level and did not progress?
Possible.
Necessary to progress.
Yeah, it's not necessary to progress.
It's
So to that
ascending
extent,
bilateral
it is,
progressive.
sorry?
It's ascending bilateral progressive static. Now it's controlled. I mean, it's, I mean, a common
Yeah,
thing, more
yeah.
common.
So, yeah,
Vomiting
to
more
that
common. That's more
extent, it
common.
is definitely possible. I only thought that from whatever description we are given, the progress was fairly slow and it was like taking support to come up. All that was a typical history of muscles, and therefore we keep that. But we take your point that it has a arrested kind of a GPS.
If you say that in GPS there is radiculopathy, then the radiculopathy has pain, elicitable or not elicitable. So maybe there has to be a pain. We have always elicited an SLR positive in a GPS. So there is an element of this is probably a painless, progressive, symmetrical, proximal more disorder of congenital origin because there's another origin restricted to spinal cord, slowly expanding as you said.
So, in summary, it is a 2 year, 7-month-old male child with 10 days history of progressive weakness of both the lower limbs with fever for 5 days, with no significant family history, with language delay in a known case of bladder extrophy in a partially immunized child, is a case of acute onset paraparesis to rule out compressive myelopathy, GBS, and acute transverse myelitis. On examination, the child was conscious and alert, afebrile.
We'll see the child. Come. ऐसा घूम इधर
असा उचलतो का अख्खा पाय उचलतो? हा, फोल्डेड असतो म्हणजे ही वॉज नॉट युझिंग द प्रॉक्सिमल मसल, ही वॉज प्रॉब्ली टेकिंग द सपोर्ट अँड देन ओके. आय मीन या असं करा, बसवा, मगासारखं बसवा. I just try and see the jerks and at the most the tone. Tone is hypotonic.
Hypotonic in both the lower limbs.
Just try.
It was Gian.
Yeah.
This. Ankle is also brisk, sir. In suspense.
Power against gravity, though he's making brisk jerks. Apparently hypotonia I have now. Maybe plantar extensor. So bilateral spastic paraparesis, symmetrical. I'm not examining the sensations. Sensations are present.
Actually, was not cooperative for sensory.
And if at all sensation is not touch and
Pain
will be going
withdraws
to
to
difficult.
painful.
Maybe pain we may be able to, touch will be difficult.
Spinal CSF. No, spine was normal, sir. There was no pain, no gibbous or kyphus or any structural abnormality as per palpation.
त्यांनी लगेच म्हणजे इथे ठाण्याच्या इथे होतं ना, तिथे त्यांनी शी केली होती.
तीन दिवसात शी नाही झाली असं झालं का? नाही झालं. लघवीच बंद झाली, करतच नव्हता किंवा सारखं टुक 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 पडत होतं, असं काही होतं का? ते पहिल्यापासूनच आहे का आता? पहिल्यापासून.
On examination, the child was conscious.
Full screen kar, full.
On examination, child was conscious, alert, afebrile, heart rate of 102 per minute, RR of 26 per minute, maintaining saturation. BP was 100/60, and peripheral pulses were well picked and extremities were warm. Anthropometrically, the child is severely acute malnourished. From head to toe examination, head is normal, there is no sweating. Ear, eyes, nose, mouth is normal. BCG scar is present on the left arm. Chest is normal. Spine is normal. Bladder extrophy is present. Genitalia abnormal with continuous dribbling of urine seen. Testes were not palpable. On CNS examination, child is conscious and alert. No obvious cranial nerve involvement. No obvious facial deviation. Nasolabial folds were preserved. No apparent squint or nystagmus. Eyeballs were moving in all directions. Response to sound is present. No shoulder drop and gag reflex is present. Uh, Tone, hypotonia in both the lower limbs. Upper limbs were normal. Power, hip joint, right as well as left, at the hip, knee, and ankle joint. The power was 3 by 5. Uh, Clonus was absent. Reflexes, wrist, knee, and ankle. Upper limb reflexes were normal. Plantar, bilateral plantars were flexor. Abdominal reflexes were present. There were no meningeal signs. On sensory system, there was withdrawal to pain observed. Other sensations could not be elicited. Straight leg raise test was negative. Cerebellum could not be assessed. So a 2-year-old, 7 month, 2 year, 7 month old male child with symmetric progressive lower limb weakness, with fever, with brisk reflexes, with preserved sensorium, without any cranial nerve involvement, without any meningeal signs in a known case of bladder exstrophy, in a partially immunized child with language delay is most probably a case of uh, acute transverse myelitis or GBS.
I guess what are the tone she said? Tone was
Hypotonia in both the lower limbs.
Hypo.
hypotonia and hyperreflexia.
Yes, sir.
Yes.
That doesn't fit. That's very difficult to fit. That I see only in a chromosomal anomaly in a or a malformation kind of situation. The reflex is normal and hypotonia. This combination of hypotonia with hyperreflexia is very, very, very difficult to explain. So can we recheck it?
So I think we may attribute the hypotonia to the nutrition. The nutrition is very poor.
But the neurological
Really look
condition,
at whether there is some spasticity somewhere. Okay, because hypotonia, yes, and a typical nutritional hypotonia with spasticity is not so easy to pick up because
absolutely.
two things: plantars are flexor, but at this age, a crying child, you won't know exactly what's happening. So I think one thing is sure that there is no lower motor neuron lesion, and there is a lesion, all right, and therefore then has to be an upper motor neuron lesion, and then we need to pick up a spasticity. And flexors, as we saw just now, could be difficult to make out with a crying child.
Because
Yeah,
whenever there
because
was
I
a
thought when you did it, it looked like extensor, but withdrawal. So I suppose we will call it as a spastic paraparesis for all practical purposes. I know that there is no typicality of all that. And in that case, those things don't go together. Acute transverse myelitis, no. Cranial barre, because there is no lower motor neuron, possibly we get out of it. So possibly we stay with our probable diagnosis of some spinal malformation getting suddenly progressive. And to me, then cyst is the most possible way.
also regarding upper motor, when this degree of hypotonia, such a severe degree of hypotonia, is due to lower limbs, he will have no power. Okay, if this degree of hypotonia with upper limb, then only he will have some. Because with such a then there should be so upper motor neuron, definitely bilateral, symmetrical, probably only motor. Sir, we have not been able to examine the sensory where you were, you may not go for pain, but touch and all may be difficult. But maybe if you pick up sensory problem, then the diagnosis becomes e- relatively easy. The bladder bowel at this stage is going to be difficult because he already has some. So between transverse myelitis or a pressure should usually give rise to asymmetric findings. Here there are symmetric findings, but if it is say congenital malformation and then suddenly expanding, otherwise we diagnose on spinal cord pressure with asymmetric involvement.
Investigations, complete blood counts were normal, LFTs and RFTs were normal, electrolytes were normal, uh, creatine kinase, sodium was low, potassium 3.5 and chloride 104. Um, Creatine kinase was done, which was normal. Bilateral USG of local hip joint was done, which was normal. Fundus examination was done, it was normal. CSF examination was done, 3 cells, all lympho, and no albumino cytologic discrepancy was seen. MRI brain plus whole spine screening was done, which was suggestive of spine having cauda equina nerve root thickened and clumped, and mild straightening of the lumbar spine and exaggerated cervical lordosis. Brain was normal. Child actually has received 3 days of MPS. Till yesterday, there was no improvement. Today, the child has shown some improvement. Our plan is to go for EMG, NCV, and decide over giving IVIG.
Thickened and clumped means what?
Sir, actually, in this image, one can see this. These are the nerve roots which are thickened, and here they are clumped. So, this is-
Yeah, but so such a radiological appearance means what?
here points towards GBS.
So GBS, we say they are inflamed, so they are enhanced on contrast, no? So not thickened, right? That's what we learn, that in GBS there is root enhancement, which is a sign of inflammation. Okay.
I, I thought whatever these three lines on spine are not normal. Okay. Uh, the question is, cauda equina nerve roots are thickened. So that's not a GBS. So the question is that what has caused that thing? Is it a result of some damage to which there is no history? Then is it something that has been a malformation? Similarly, look at the mild straightening of the lumbar spine. Why is that lumbar spine straightened? So it's obviously not a orthopedic problem. So again, to me, it might be something related to again a spinal lesion. And same thing is about the exaggerated cervical lordosis. We don't know why that is so.
I thought arachnoiditis can give rise to such a thickened and clumped cauda equina, and it could be generalized. Yeah, result of something. So that we need to find out. Just like when you asked me about vasospasm, in that case, I couldn't tell you anything because simple subarachnoid hemorrhage in an adult causes vasospasm. And today, when we see vasospasm, we talk about cocaine. So anybody who's a cocaine addict in a big child, we think of, you can have your cranial vasospasm also. You'll have to see the differential.
So one defect is often comes with another defect. So sir was asking what AI helps. So AI says that bladder dystrophy is often associated with spinal defects like diastometamelia, split spinal cord, or other genital anomalies, anorectal anomalies, epispadias, etc.
I think what we would request you is you talk to your radiology department, and as sir said, see, cauda equina nerve roots thickened and your root enhancement of GPS may be different. It's not the same. So ask them what is the meaning of this. Means what should we interpret this as?
Sir, they had given three TDs from their side. One was GBS, the other was arachnoiditis, and the third was chronic demyelinating disorder.
Based on this appearance, they are saying GBS, arachnoiditis, and chronic demyelinating disorder. That is based on this appearance of this nerve roots. Yeah, need a neurologist opinion. Yeah.
Typical arachnoiditis should have a CSF abnormality.
Chronic inflammatory demyelinating.
Okay, this CSF is normal, so that doesn't look like that.
When we call this as a
GBS,
bilateral
arachnoiditis,
spastic
and chronic
paraparesis,
inflammatory
the question
demyelinating
is,
polyneuropathy.
when we call it a bilateral symmetrical spastic paraparesis, the question of GBS should be.
I think our complaint on this clinic has been we never know what has finally turned out to be because different people would come next time. Okay. And we lose all this clarification. So if you are not coming, please leave a message with somebody who is coming. Okay. Because otherwise, we don't end up with a definitive diagnosis, then we have not learned, right? So I suppose I request next time if you're not coming, please find out who is coming and let them give us a message from you. I think then only we can learn, isn't it?
I was just thinking loud. Cauda equina, which we see in adults. Cauda equina. And you can have a lower motor neuron, right? The hypotonia can be explained.
Okay, thank you. Thank you. Our online audience, any more comments or points you want to make? Yeah.
Rajesh?
Yeah.
The students, both the children have completed only 9 months vaccination. So how should the first child's vaccination be completed?
Okay, answer. The first child was 4 years something, no? So now with 9 months, they have stopped vaccination after 9 months. So you want to continue beyond that. So what will you do today? So what all is pending?
PV booster, vitamin A, and MMR.
So DTP, OPV boosters and second dose of MMR and
Vitamin A.
and he's 4.5, no? The first one.
IPV,
So how will you schedule all this?
Boosters we can give. Vitamin C.
what is the priority? DTP, IPV is definitely a priority. One MMR, if he has received by chance, it becomes relatively less of a priority. So DPT, IPV, IPV definitely. Then amongst what is left is measles, chickenpox, typhoid, janido. Then the MMR becomes the next priority. So a combination of DTP, wholesale, and IPV, and maybe simultaneously with MMR at the same time, and then you will repeat the DTPs. If this is going to be the booster dose, perhaps. So booster dose, and then the subsequent. I mean, typhoid and chickenpox and hepatitis are hardly emergencies. Out of them, I may consider chickenpox first because this is airborne disease and therefore relatively difficult to prevent. Waterborne diseases like enteric fever and hepatitis A are theoretically possible to prevent.
Only thing is that IPV standalone is not available. So therefore, you will have to go for a combination of acellular DTAP, which is available with IPV, right? So you'll give both at the same go, MMR and that thing. Correct. Anything else from the online audience? Okay. So we'll stop here. Thank you everyone for joining in, and we meet next Thursday once again.
Thank you, Dr. Amdekar. Thank you, all faculty. Thank you, Rajesh. Thank you,
Thank
all
you.
the students for presenting lovely cases.
Thank you. Thank you. Bye.